Well, good evening. I'm Jennifer Blomquist. Thanks so much for joining us on Healthline. I appreciate you tuning in. In case you're not familiar with this show, it is a live call-in program, and we have an OBGYN here who will be happy to answer your questions. The phone number is at the bottom of your screen. We'll keep it up for you throughout the program, which lasts until 8 o'clock, so you got a little bit of time here. It's 969-2720. It's still a toll-free call. If you're outside of Fort Wayne, just put an 866 in front of there, and we'll get you through to the doctor so you can ask your questions. So why don't we go ahead and meet our guest tonight and proceed with the program. This is Dr. Geoffrey Cly. You've been a guest on here before, so thanks so much for coming back.
Thank you for having me back.
And again, Dr. Cly is an OBGYN. And we're going to focus in on a particular topic. If you have something else that's not specifically about that, you're welcome to call. But we're going to be talking about endometriosis and robotic surgery. And I think a lot of people probably, Dr. Cly, are familiar, or at least have heard about robotic surgery. Endometriosis is kind of a big word, might sound kind of scary. So it is a disease, is that correct?
A condition.
A condition, okay.
It's a condition where the menstrual tissue that comes out normally with a period gets kind of stuck inside the body cavity and outside of the tubes, outside of the ovaries, outside of the uterus, and causes pelvic pain, discomfort, because inside the body it's having its own little period, so to speak. So that bleeding is occurring inside the body cavity, which causes inflammation, tenderness, and can lead to scar tissue and challenges with infertility and ability to get pregnant.
Does this happen over over a long period of time, or I mean, would a woman just not be having any periods, and this is occurring internally?
It can actually happen to up to 10% of women.
Okay.
It typically will start when a woman or a young woman starts having her periods.
Okay.
And it starts, the tip-off signs are heavy, crampy, painful periods. A lot of times if we see young women who are missing school, they're having to take a lot of Advil or Motrin because their periods have always been very, very painful. That's many times a sign that they have endometriosis starting. And usually we also recommend coming in to be seen in those early years to prevent it from becoming an issue where it causes problems with pregnancy later. And if not in those early years, it may be in the mid-20s or sometimes 30s, maybe after having children, where the periods get more heavy, crampy, and pelvic pain occurs, pain with intercourse, even pain with the bladder area.
So how do you diagnose it? Do you have to do a test or some kind of screening? Or?
First, we start by history and exam, and many times we can actually do an exam and feel the tender spots during the physical exam, and so that's the first sign. The official diagnosis is by looking with a laparoscopy, but we try to avoid surgery if possible. So we usually try non-surgical treatments first, and then if those don't work, we'll talk about looking with a laparoscopy to remove those areas.
I know typically a physician would prefer to do something conservative instead of more invasive. So what do you do? What would be a conservative form of treatment? What are some options there?
With Advil or non-steroidals, like Advil Aleve works well, naproxen during the period, but also trying to suppress the periods by using some type of hormonal control or birth control, not necessarily for birth control, but to suppress the menstrual cycle so that they don't have that release of the pain chemicals and then the bleeding internally when those areas happen.
And then supposing that those methods don't prove to be helpful, then you'd probably go to the laparoscopy. Yeah,
then looking with the laparoscope, and that's where we're having a revolution and a breakthrough now, where we haven't had in the past, and that's because of the robotic technology.
Yeah.
So in the past, we've gone in laparoscopically and we've looked and found these areas that look like scar tissue, sometimes like powder burn areas inside the body, on the bowels, on the bladder, on the fallopian tubes. And all we've been able to do is burn them off or laser them off. But what that does is it leaves the residual scar tissue. So those areas are still tender. They are likely to come back because we haven't removed those cells. So with the technology that we used to have, we couldn't do any more than that. Or we would have to open up and make a big incision like a C-section. Now with the robotic surgery, the dexterity from the robotic incisions, it's like we have our own hands in there and we can move around, but our instruments are only 5 millimeters or smaller. So now we can actually remove the little areas piece by piece so that the patient's completely free of endometriosis after surgery. And the results are phenomenal, how well people are feeling now after having a robotic laparoscopy for endometriosis.
Once you have that surgery, are you usually free, or are you at risk of this returning, having this condition again? Or?
Yeah, by removing those areas at the time, you can be free of endometriosis for the moment. It does try to return, so after surgery, we usually find people who are feeling normal again, and they're back to life fast, and they can drive the next day, they go home the same day.
Oh, it's not even, I figured they'd have to stay in the hospital for a few days. No, huh?
Yeah, they go home usually a couple hours later.
Oh my
and or if they're a young woman, back to school in probably 2 days. I usually recommend taking the next day off of school or work just to be safe. Or even trying to get pregnant the next cycle that they have. And then if they don't want to get pregnant at that moment, we usually suppress then the regrowth of the endometriosis so that we try to get a pain-free interval of several years before anything would try to come back.
That is the one thing I had heard about endometriosis, is that it can cause problems with fertility. So somebody who's been diagnosed with this, are they automatically going to need to have some fertility, a specialist help them? Or?
Not automatically.
Okay.
And that's been something that I really try to help teach patients about, is endometriosis doesn't mean infertility automatically.
Okay.
So when we find young women with endometriosis, we want to treat it when they're young. Right. If we wait and just try to treat the pain but we don't take care of the endometriosis, then it could cause scar tissue. So by the time they're ready to have a child, then the scar tissue causes infertility. But if we treat it when they're young and don't wait until that scar tissue happens, we can prevent it from ever causing a problem, so they will be able to have children normally. And that's one of the best things to do, is just to know you can help someone and they can still have a family later on when they're ready.
Sure.
Because many women are waiting until late 20s, sometimes 30s, before they start their families.
That's good to hear. I mean, I'm just so impressed by how quickly you can recover from that kind of surgery, because in the past, when you're talking about having to do an incision the size of what you do for a C-section, I mean, that was a 6 to 8 week recovery period, I would think. So.
Oh, you're right, and that's what's so also wonderful about this, is because we used to say before we had this technology, you have this large surgery, laparotomy, and then we'd say you need to have your kids right now, and then you need a hysterectomy. We don't need to say that anymore, because you don't need a hysterectomy anymore. And that's what's wonderful, is women do not have to have things taken out of them to be treated to feel normal. I've taken care of a few women who've had that happen, and they feel so bad because they come to me and their uterus were already taken out when they were 22, 23, 24. And now we don't have to do that. So it's really nice to be able to offer that to patients and say, yeah, you're going to be okay. You're going to be able to have a family, and you can have that family when it's right for you.
That is, amazing. Quite a turnaround from what it used to be. So. I want to remind everybody that our phone lines are open, and we welcome any questions you may have for Dr. Cly. It's 969-2720, or it's 866 in front of there. It makes it a toll-free call, just in case you're outside of Fort Wayne. The phone lines are open now, and we'll keep them open until just about 8 o'clock when the program ends. So please give us a call. We did have somebody, Dr. Cly, call in, but they're a little bashful, so they wanted me to ask the question for them. So it was somebody named Ann, and she wanted to know if endometriosis would run in your family, if it's hereditary.
Great question. It does seem to run in families. So we don't know exactly what the source is. There is a hereditary component. It also can seem to occur from women who have periods in the tissue spills through the fallopian tubes and just lands in the body cavity. So the hereditary component, we don't have a gene, we don't know how it happens, but yes, it does seem to many times run in families. It's not automatic, though. But if a mother has it and her daughter starts having very severe painful periods as a young teenager, I'd recommend having her evaluated.
You had kind of touched on this before, but I'm assuming most young women, would see a doctor hopefully on a regular basis. But as far as going to see a gynecologist, should you wait until the onset of menses, or should you wait? Maybe just go when you're 16? What's the guideline? Yes,
they've changed recently, and so we recommend when you're 18, or if you're sexually active, come in to see a gynecologist. If a young woman has difficulty with her periods, either the painful, very heavy, maybe as a 13, 14, 15, 16, 17-year-old, then definitely come and see the gynecologist. And the other thing is we don't automatically have to do an exam. So I have many young teenagers right now where I haven't had to do an exam. So because they haven't been sexually active, it's very traumatic to do that exam. So most of the time we'll try to put that off until we really, really need it, because it's just a big event in their life. And if it's not going to change our treatment plan, then we don't necessarily need to do that. And that part of that is because of ultrasounds can act as an exam, and you can see inside the body with an ultrasound. So that helps a lot of times.
Oh, I'm sure it is kind of intimidating for the younger girls for the first kind of visit like that. So.
Yes.
Well, we did get somebody who wanted to ask you a question, so I'm going to go ahead and toss the phone line over to Teresa. Did you have a question? Hi, Teresa, are you there?
Hello.
I don't know if we lost Teresa or not. Well, I'm going to go ahead. I'll paraphrase her question for her. She said that she had had a hysterectomy 2 years ago, and says that her sexual activity or sexual life is not very good right now. So I don't know if you want to.
Yeah, a couple things.
That.
Yeah, a couple things on that. That's a common thing we hear, and it could be because, Teresa, if you've had your ovaries taken out, that the hormone levels in your body have gone down, so that would affect your libido, sex drive. It can affect some dryness and comfort levels in the pelvis. Those can be corrected, though, so I would check with your doctor, because sometimes we can add back some of those hormones. Also, it could be, what if she kept her ovaries, but there's some scar tissue where the uterus was? That also can be fixed with physical therapy. Sometimes a rechecking with an operation, but usually physical therapy can make a huge difference for difficulty with intercourse or pelvic pain after a hysterectomy.
All right. Well, Teresa, thank you so much for your call. And you touched on physical therapy. We had a physical therapist who's quite well known in town, and it's amazing the things she has done for women. Helped to correct incontinence, painful, episodes like that during sexual intercourse. So some people would never think to go see a physical therapist for that, but gosh, she just has had amazing stories to tell.
And I recommend her and some other people all the time, because you're right, it's amazing to see the results from physical therapy. A lot of people come in thinking they need a surgery for pelvic pain or even urinary incontinence, and many times by doing some physical therapy and what the strengthening exercises that they're taught and the maneuvers they can do, they come back to me and say, I don't need surgery anymore. And I think that's fantastic. So I always try to go the non-surgical route before doing any surgery. Surgery works great, but it's not always necessary.
Yeah, and if you don't have to have it, it's certainly something you'd rather avoid.
Right.
So, well, if you'd like to ask Dr. Cly a question, he's going to be here until about 8 o'clock, and the phone lines will be open until that time. It's 969-2720-866 in front of there makes it a toll-free call. And again, please give us a holler. We're waiting for you to get in touch with us. In the meantime, we're going to keep talking a little bit about endometriosis and robotic surgery. The one thing about robotic surgery, since it is newer, would insurance automatically cover it? I would imagine that could be an issue.
Yeah, great question. It is covered like a normal laparoscopy.
Okay.
And so it's billed just the same. It's another tool that the hospital has that can use to get a better outcome. And I was the first in town to do the robotic surgery back in '06. I started, and so I do a lot of robotic surgery, and I just found at that time that it was revolutionary in how well I could treat patients and how fast they recovered. The pain levels are almost non-existent. The complication rate is so low. The bleeding is so much less. We sometimes lose a teaspoon or less of blood, where we used to use a whole cupful.
Sure.
And so I actually go out now and I teach other doctors. I've taught a lot of the doctors in town, and I teach all over the nation, because it's just so revolutionary. And getting women back to life faster is amazing. And now this endometriosis treatment, the research we found with using the robot for endometriosis is now just a wonderful breakthrough. We've already found that for hysterectomies, women don't need to have the big incisions anymore. I have women going home with the same day with hysterectomies, in pelvic prolapse surgery. They're going home the same day. I had an 80-some-year-old lady go home, and a week later she went to her bridge club after a major
Isn't that
pelvic
amazing? Oh,
and
my
her
goodness.
friends were like, "You can't be here."
Yeah.
And she goes, "I feel fine." And it's the same thing now with endometriosis. We can make such a difference for people by using the robotic surgery.
Well, certainly if anyone's watching who has known somebody who's had endometriosis, I knew somebody years ago who had it, was out of work for a month and a half, unable to have children afterward.
Right.
It was an absolutely miserable experience for
Yeah.
her. And to listen to what you're telling me now, I
Yeah.
mean, it's just a 360-degree,
Yeah.
turn there. So that's amazing.
Yeah, and another thing we've found is that a lot of times with endometriosis pain, women have bladder irritation and bladder pain, and that's something I've kind of learned through my patients, and I wanted to solve the question is, why do women have surgery and they fix the endometriosis but they still have pain? And it turns out it's actually part of the pain might be in their bladder, and medicine and some diet changes fix that. So we don't need
you
to
don't
do
have to
surgery.
do it, go back and do surgery in the bladder.
Right.
Okay.
So I have a couple women who had hysterectomies. They came to see me afterwards. They had them somewhere else, and they couldn't believe they said, "Why am I still in pain?" So is their bladder. So that's we're also trying to teach that those two things go together. So if you're out there and you have pain from endometriosis and you're told you just have to live with it, you don't have to live with it. It's going to be in your bladder, and we can help. We can make a difference so that you don't have to live with pain. And I don't know, I just hate it when I hear doctors say,
I hear
just
that
tough
a lot
it up.
too.
And it's not true. Something's going on. We just need to keep looking to find it and fix it.
Well, and it goes back a long time ago. People just always stereotyped women as, they're having their period,
Right.
you should feel miserable. But that's not the answer that is given today.
Absolutely. It's not fair to treat people like that. So I always think about how would I want to be treated, and I always say, because sometimes people say, well, she's faking it or it's in her head. I'm like, really? Did she want to take a day off of work? Did she want to interrupt your life to come and wait in my waiting room? And did she want me to make her feel pain because she's making it up? No, there's really something going on. It's just a matter of let's find what's going on and let's fix it.
Well, it's good to hear that people are willing to listen. So now, well, we do have somebody who wanted to ask you a question.
Great.
So this is it Barbara?
Yes.
Hi, thanks
Hello.
for calling. Go ahead with your question.
Well, my daughter is in her late 20s and nearly 15 years ago had one of her ovaries removed. Now, will it be harder for her to get pregnant with just one ovary, and will it get harder as she ages?
No, it should be the same. Each ovary will produce enough hormones to provide the eggs and just hormones for when she's not pregnant or not trying to get pregnant. And so she should have the same exact ability to get pregnant with one normal ovary as with two ovaries. And actually every month, each ovary, when you have two ovaries, tries to be the first to produce the egg. And then the first ovary to produce the egg is the dominant follicle and takes over in the early stages of pregnancy. So that ovary that she has right now doesn't realize the other one's not there. So it's just continuing to try to produce the eggs and produce the hormones like normal.
Did you want to ask anything else, Barbara?
No, that makes sense.
All right. Well, good luck to your daughter. Thanks for calling.
Thanks so very much.
Thank you. Take care.
Bye.
And that is something, it sounds like her daughter was probably in her teenage years then when she had that done. And at that point, a lot of girls and young women are not thinking about having a family. It seems so far away. What do you recommend, especially if somebody's had complications, as an ideal age to, if you're in obviously a committed relationship and ready to have a family, instead of putting it off, how should you look at that age-wise, no later than 30 or 35?
And with or without endometriosis, either way?
I guess, yeah. Well, what if you have a complication? Should you really think about going earlier?
I think, if you have one ovary because of a complication and you're in a position to have a family in your 20s, I would say go ahead and think about pursuing that family, only because you had one ovary removed for a reason. So there is always a small chance that something could happen to the other ovary.
Okay.
But that being in the position is, what's the key. So I usually tell people if they're married and they, something's going on, maybe a year or two after, enjoying being married and without children, think about trying to start that family.
Yeah.
But I wouldn't usually say go out and settle on a partner you don't
Yeah.
really, you don't
Yeah,
really wanna
no,
be
that's
with.
not a good way to
Yeah.
approach it.
And a lot of women are wait until their 30s now because of just life and how it
Sure.
happens. And so we find a lot of women having pregnancies and babies in their 30s, and the challenges go up after 35, but that doesn't mean you can't. Just got to be aware of what it's going to be like and what your lifestyle is like in order to have a successful pregnancy.
So maybe just kind of planning ahead, at least having a discussion with your doctor wouldn't hurt.
Yeah, that's
So.
just having that discussion is really important.
All right. Well, we've got just 6 minutes left now, so the show is going very quickly. We would welcome any more calls. We still have time to take some. So 969-2720-866 in front of there for a toll-free call if you're outside of Fort Wayne. And again, now we're probably closer to about 5 minutes left in the program if you want to get in touch with Dr. Cly and ask him a question. With the robotic surgery, I mean, we talked about endometriosis. You're also talking about being used for hysterectomies. Another topic we get a lot of calls on, or we have in the past, is the prolapsed
Prolapsed bladder, pelvis.
lower pelvis. Can you use robotic surgery for those conditions?
Oh, it's fantastic for the hysterectomies. It's wonderful for pelvic prolapse when you need surgery. And actually, I used to do the other route of surgery, the vaginal route, but there's so much more complications, and the infection rate is so much higher that in 06 or 07, I can't remember which, when the studies compared robotic surgery to the vaginal surgery route came out, and it was so clear, crystal clear, that the robotic surgery is so much better for patients for longevity. The complication rate is so much less. You feel back to normal, and the results last for years, that I said, I got to learn how to do this. It's the right thing for patients.
Yeah.
And so I've been doing pelvic prolapse surgery with the robotic system since then, and it's just phenomenal how well it works. And it even works well for patients who've had failures from other routes. So we're now able to help those patients, and we don't have to make incisions in the pelvis or vagina, and we don't have to do all these sutures, and they don't have to have all the discomfort. So it really is revolutionary. And especially you talked earlier about a patient, Barbara's daughter.
Yeah.
Or someone with one ovary. The nice thing about the robotic system is it's very easy, and I'm maybe using that term a little loosely, to go do the surgery, fix that ovary now, and then let them go home the same day and be normal. Whereas in the past, 15 years ago, they had to remove the ovary. And so I would also tell patients that if your doctor's saying you need to have your ovary removed and you're still in childbearing ages, I'd ask that doctor, can you do this with the robot? Do you know how to use the robot? And if not, can you send me to someone who can save my ovary? Because we frequently can save ovaries by fixing them, and we try not to remove tissue and organs now because we don't have to.
And that's nice, because I think a lot of women just thought they had no option, other options. I mean, hysterectomy, they used to just take everything, and a lot of women had that hip-to-hip incision. So I mean, it's nice to know that at least you should inquire about if you're a candidate for the robotic surgery.
Same with fibroids now, because fibroids are growths in the uterus. They're benign, but they're gross, and they can get big. They can cause heavy periods, difficulty with getting pregnant, pelvic pain, heavy bleeding. And with the robot now, like I did a case just a couple weeks ago, she didn't want to have a hysterectomy. So we just took the fibroids out and put some stitches in. Her uterus is back to normal. She's having normal periods now. And without the robotic system, she would have had to have a hysterectomy. So it's changing everything. And now I didn't have to say, you need a hysterectomy. I said, we can fix this if you'd like. And she loved that option.
That is, it is a wonderful option to have. And I'm just wondering, I mean, at some point, would these other would have been traditional forms of surgery, will they just be obsolete? You think robotic will pretty much be mainstream?
Yeah, just like laparoscopy is done for appendixes and gallbladders.
Yeah.
It's unheard of to have an opened appendix now where you had the big incision.
Sure.
So the robotic surgery is doing the same for women's surgery.
All right. Well, it's nice to know that that is an option. As Dr. Cly had said before, because I mean, insurance is a big issue, and sometimes that determines that makes up somebody's that makes their mind up for them, I should say, when their insurance dictates what they can and can't have. But you're saying that robotic surgery is covered like any other type of surgery.
Yeah, it's just another tool, just another instrument we use to do the laparoscopy, so it's covered the same.
All right. And I'm guessing too with some of these, I mean, looking at the bigger picture, you're talking about quicker recovery times. Do they need any additional, I mean, does it, I guess in the big picture, restrict them? Does this change any other form of their recovery as far as making it more difficult? I'm looking at the small picture where it's shorter, you know, getting back on your feet quicker, but long term down the road, does it make any difference?
No, no, they do so well. Women can frequently go back to work in 1 to 2 or 3 weeks. Many women though still have a 6-week option, and so they say, you know, I've earned my 6 weeks off, so I want to take my 6 weeks off. So they still can. Because insurance says, yeah, that's fine because of the it's classified as either a hysterectomy or a pelvic prolapse. But they feel good now.
Sure.
The one challenge we now have, though, it's interesting, is now that they feel so good, they're doing so much more. So they forget they have surgery because a week later they may not have any pain. I had one lady move her entertainment center, and then she had some pain.
Idea. Yeah, okay.
She didn't break anything, but she came in that was Sunday. She came in Monday, and she said, "Oh my gosh, I was feeling great until I lifted something." I'm like, "What'd you lift?" And she goes, "My entertainment center." I'm like,
no big deal.
You still got to take it easy a little bit.
Oh, goodness. Well, that's a good lesson learned. So,
Yeah.
well, we are out of time, and it's been great having you, Dr. Cly. I appreciate your time.
Thank you.
Thanks so much to all of you who called tonight. And we are going to see you 1 week from tonight. We'll talk about physical medicine and rehabilitation with Dr. Eric Schreier, 7:30 next Tuesday. I'm Jennifer Blomquist. Take care. Have a good night.